and welcome to this presentation. We're all trying to improve healthcare by improving data. And here I would like to show you an example of how to improve data and healthcare in the case of hemophilia blood disease. My name is Marcel.
Yeah, so it goes to automatically to the same to the new slide. So that's good. Okay.
Perfect.
Yeah.
So I'm going to show a sponsor slide starting at 9:50 Eastern. And then right at time, I will turn it over to you.
Okay.
And let's see, are you hitting record on the Zoom or am I doing that?
You're doing that.
Okay, I will do that. And you've done your introduction yourself on your slide, so I won't.
Yeah, exactly.
Okay. Could probably put the slide up now.
Yeah, I see a slide.
Okay. Oops. Interesting. It won't let me make you a co-host.
Okay, sure. You asked me to unmute, right?
Yeah, it would be helpful if we're supposed to make it so that participants can't unmute themselves, but because, oh, there, now you're a co-host. Yay.
Yeah.
Okay.
Good. So now I'm able to, yeah, unmute.
Yes, and so now the participants won't be able to. Okay.
Yeah, check.
We have a couple of attendees joining. Welcome. We will get started in just a moment. Here we go. Welcome, everybody. We will get started in just a moment. All right, welcome everybody. Welcome to Turning Data into Better Healthcare, Handling Data for Hemophilia Blood Disease. Marcel, are you ready to get started?
Yes, thank you, Anne. Welcome everyone to this presentation. It's all pre-recorded, so but I will be happy, of course, afterwards to answer your questions. Let me share my screen.
Hello, everyone, and welcome to this presentation. We're all trying to improve healthcare by improving data. And here I would like to show you an example of how to improve data and healthcare in the case of hemophilia blood disease. My name is Marcel Hofman, and I'm privileged to work as the lead data engineer at Logect MRDM. So please allow me to introduce Logect and MRDM. Turning data into better healthcare, that is our mission. Logect is leading the way in healthcare analytics. We empower stakeholders at every level of the healthcare system by bringing clarity to the decisions that result into the best possible healthcare. Our solutions transform data into actionable insights, showing exactly where to take strategic action that leads to the best possible outcome at the lowest possible cost. At MRDM, our custom-built platform makes it easy for healthcare providers worldwide to collect, process, and analyze their outcomes data and deploy those findings towards better healthcare. We securely collect, process, and analyze a variety of national and international health outcome datasets to enable healthcare providers to benchmark and improve outcomes. Although most of you probably know, let me briefly describe hemophilia. Hemophilia is usually an inherited bleeding disorder in which the blood does not clot properly. This can lead to spontaneous bleedings, as well as bleedings following injury or surgery. Blood contains many proteins called clotting factors that can help to stop bleeding. The severity of hemophilia that a person has is determined by the amount of proteins called clotting factors in the blood. The lower the amount of these proteins, the more likely it is that bleeding will occur, which can lead to serious health problems. Hemophilia is caused by a mutation or change in one of the genes that provides instructions for making the clotting factor proteins needing to form a blood clot. This change or mutation can prevent the clotting protein from working properly or to be missing altogether. The genes are located on the X chromosome. Hemophilia can result in bleeding within joints that can lead to chronic joint disease and pain, bleeding in the head and sometimes in the brain, which can cause long-term problems such as seizures and paralysis. And death can occur if the bleeding cannot be stopped or if it occurs in a vital organ such as the brain. The registry used in this project is called the HemoNet registry. The most important objective of this registry is to improve the quality of care for people with hemophilia and associated disorders. This can be achieved by continuously recording, compiling, and comparing information about their disease, treatment, and treatment results. A continuous follow-up is indispensable. Detailed information about the patient's infusions and bleedings are recorded in a digital infusion log by patients who receive home treatment. The information from the digital infusion log is sent to the registry. Hemophilia practitioners can conveniently access this information on their own patients and discuss it during consultation visits. After anonymization of the registry data, it can be used for different purposes. First, giving insight into the total number of patients with hemophilia in the Netherlands, their diagnoses, the use of coagulating factors, bleedings, treatment results, and side effects of the treatment. Second, comparing the quality of care of hemophilia treatment centers in the Netherlands and abroad. Third, reporting side effects of medication. And last, providing information for reports, scientific research, and safety studies for new medications. Before we go into the ins and outs of this project, let me share the project outcomes with you. We set up FHIR connectivity for handling data for the HemoNet registry, where lab data was modeled in loin codes and connected with patients. We achieved increased interoperability between hospitals as we could add datasets parallel with other hospitals. The project also created proof points for automated data delivery based on standards with multiple hospitals, and also opened up opportunities to expand to other registries with these hospitals, which as a result led to reduced registration burden and also reduced the manual input. In order to increase interoperability, we have mapped the multiple data sources and datasets, including patient medication data and lab data, to a standardized dataset to be used by the HemoNet registry. This mapping is based on the hospital's electronic medical record and not on the hospital itself. The electronic medical record in this project is the leading one in the Netherlands. We have created a standardized FHIR endpoint for each organization, which is hosted by us. In that way, we can easily replicate the setup for other hospitals in the future. Well, setting up and maintaining a registry is not always a walk in the park. One of our goals for this project was to reduce administrative burden while expanding outcome measurements and improvement. Registration burden can be defined as the number of variables in a registry times the number of patients times the minutes to complete manual data input. The linking of multiple datasets enabled the registry to be used both for research and care. Instead of the practitioner having to manually enter data required for the registry, we could now transfer the data easily by profiling and standardizing a mapping from FHIR to the registry. The participating hospital modeled the LOIN coding so that we connected these codings to the patient data. As a result, the lab data could be directly transferred to the registry. Well, what's the worst that could happen if erroneous data entry errors occur? For any industry, lost time and revenue are common. For healthcare, the result could lead to diminished healthcare practices and poor health outcomes. For this reason, we aim to standardize and automate the processing of the datasets so that manual data entry is reduced to the minimal. The clinical data, consisting of patient data, medication, and lab results, were profiled and validated to both the registry validation rules as well as the FHIR STU3 validation rules. We built a data transformer to fully translate these datasets to the registry, which has the benefit of not interfering with the data structure of the source data. In the end, we were able to drastically reduce the manual data input. And after successfully completing this project, please allow me to share the lessons learned. First of all, we found that the LOIN codes are not always consistently applied by hospitals. For example, Hospital A may have set certain LOIN codes for lab definitions, whereas Hospital B may have none or actually have different LOIN codes. Secondly, we found that there's a lot of changes also in the definitions and equipment used by laboratories, and that can also change actually the LOIN codes themselves. And last, we are aware that with a new electronic medical record, we would also require a new mapping to FHIR resource. And last, feel free to reach out to me. I'll be pleased to connect, and if wish to provide you with more details about the project. Well, thank you for your time. I hope you enjoyed the presentation, and I'll be happy to answer your questions.